Hello and welcome back to the Irish Hematology Oncology podcast, the show where we break down complex cancer topics into friendly chats that you can have with your colleagues over a cup of tea. I'm your host, Eoin Tabb, a clinical cancer services pharmacist working in University Hospital Waterford. Today, we're diving into the world of immune checkpoint inhibitors, or ICIs they're sometimes called. These drugs are revolutionizing cancer treatment, but they come with a unique set of side effects that we need to be prepared for. Think of ICIs as the superheroes of cancer therapy. They unleash the power of the immune system to fight cancer cells, but sometimes, like any superhero, they can cause a bit of collateral damage. That's where we come in. As healthcare professionals, it's our job to understand these side effects, known as immune-related adverse events, or irAEs. I don't like using that term, so I'm not going to use it in today. I find it a bit of a mouthful. But yeah, it's for us to know those side effects and how we manage them effectively. Now, you might be wondering, what exactly are immune-related adverse events? Well, they're not your typical chemotherapy side effects like nausea or hair loss. These side effects are caused by the immune system going into overdrive. You see, our immune system is like a well-trained army, constantly patrolling our bodies for anything that doesn't belong, like bacteria, viruses, or even cancer cells. To do this effectively, it has a system of checks and balances, like checkpoints and border crossing, to make sure it doesn't mistakenly attack our own healthy cells. These checkpoints are regulated by proteins on immune cells, such as PD-1, or programmed cell death protein 1, and CTLA-4, cytotoxic T lymphocyte-associated protein 4. But cancer cells, they are sneaky. They've figured out how to disguise themselves and evade the immune system's checkpoints. It's like I'm wearing an invisibility cloak. So that's where these immune checkpoint inhibitors come in. These drugs are like a spotlight that shines on the cancer cells, revealing their true identity to the immune system. This allows the immune system to recognize and attack the cancer cells more effectively. However, sometimes this spotlight can be a bit too bright. It can cause the immune system to become overactive and start attacking healthy tissues as well. This is what we call an immune-related adverse event. It's like the immune system, in its zeal to fight the cancer, accidentally starts firing on friendly forces. The areas most affected are the skin, the endocrine system, liver, gut, and lungs. The type and severity of immune-related adverse event can vary depending on which checkpoint is being inhibited and which organs are affected. For example, anti-PD-1 therapies are most often associated with lung inflammation, pneumonitis, while anti-CTLA-4 therapies are more often associated with gut inflammation, colitis. Combination therapies, which block both PD-1 and CTLA-4, can lead to a higher risk of immune-related adverse events overall. Now, the good news is that immune-related adverse events are manageable, especially if we catch them early. That's why it's so important for us to be vigilant and know what to look out for. Early recognition and prompt management are key to minimizing the impact of immune-related adverse events and ensuring that our patients can continue to benefit from immune checkpoint inhibitors. I've just realized that I've gone through that section there and I've spoken about PD-1s, PD-L1s, CTLA-4s without actually telling you the drugs that they are associated with. So let's go through those there. So PD-1s, checkpoint inhibitors that block PD-1, including nivolumab and pembrolizumab. They're usually used to treat melanoma, Hodgkin's lymphoma, non-small lymphoma. Pembrolizumab is exploding with indications that it has become approved for. So then you have CTLA-4. So ipilimumab is a checkpoint inhibitor that blocks CTLA-4. Again, used for advanced melanoma and advanced renal cell cancer. So there you have your two. So ipilimumab and nivolumab generally are your two combination products of CTLA-4 and PD-1, which can cause a wider range of immune-related adverse events. And then you also have your PD-L1 checkpoint inhibitors. So there you have atezolizumab, avelumab, durvalumab, and more coming online. So in the next segment here, we'll dive deeper into some of the most common immune-related adverse events and discuss how we can manage them effectively. So let's talk about those most common immune-related adverse events you might encounter in your practice. So first of all, you have those dermatological toxicities. Skin reactions are the most common immune-related adverse event, kind of like a sunburn from the immune system getting a bit overzealous. These reactions can range from mild rashes and itching to more unique presentations like vitiligo, where patches of skin lose their colour. For mild cases, we can often manage these with over-the-counter hydrocortisone 1% cream, but for more severe cases, we might need to bring in the big guns with prescription-strength topical corticosteroids like betamethasone or clobetasol. If the itching is bothersome, we can add in an antihistamine like cetirizine or loratadine, giving the skin a bit of TLC there to help it recover. Then you have endocrine. So immune checkpoint inhibitors can also mess with the endocrine system, the body's hormone control center. It's like a thermostat that's not working properly, leading to the house being too hot or too cold. Immune checkpoint inhibitors can cause a variety of endocrinopathies, but the most common ones are hypothyroidism, an underactive thyroid, hyperthyroidism, an overactive thyroid, and adrenal insufficiency. Hypothyroidism is like the body's metabolism slowing down, leading to fatigue, weight gain, and feeling cold all the time. We can easily manage this with levothyroxine, a synthetic thyroid hormone that replaces what the body is missing. Hyperthyroidism, on the other hand, is like the metabolism going into overdrive, causing weight loss, rapid heartbeat, and feeling hot and sweaty. This might require beta blockers to manage symptoms, and sometimes steroids or anti-thyroid medications to calm the thyroid down. Adrenal insufficiency is a more serious condition where the adrenal glands don't produce enough hormones, leading to fatigue, low blood pressure, and electrolyte imbalances. Then you have hepatotoxicity and pancreatitis. So now let's move on to the liver and the pancreas. So immune checkpoint inhibitors can sometimes cause inflammation in these organs, known as hepatitis and pancreatitis, respectively. Think of it like a small fire starting in these organs. We need to put this fire out quickly before it causes too much damage. For hepatitis, we typically start with oral prednisolone, a type of corticosteroid. If that doesn't do the trick, we might switch to mycophenolate mofetil, or even bring in Cavalry with tacrolimus or anti-thymocycline. For pancreatitis, it's all about pain management and giving the pancreas a break. This might mean a low-fat diet, IV fluids, and pain medications. Then you have gastrointestinal toxicities. The gut is another common target for immune-related adverse events. Diarrhea and colitis, which is inflammation of the colon, are the most frequent culprits. It's like the gut lining gets irritated and inflamed, leading to abdominal pain, cramping, and frequent loose stools. The first step in managing these GI toxicities is to rule out other potential causes like infections. If it's confirmed that it's an immune-related adverse event, we can usually manage mild cases with loperamide, which is an anti-diarrheal medication. For more moderate cases, we might step up to budesonide, a type of corticosteroid that works locally in the gut. And for severe cases, we might need to use systemic corticosteroids like prednisolone or even biologic therapies like infliximab. Then we'll move on to pulmonary toxicities. So immune checkpoint inhibitors can also cause inflammation in the lungs, a condition known as pneumonitis. It's like a chest infection, but instead of being caused by bacteria or viruses, it's caused by the immune system. Symptoms of pneumonitis can include cough, shortness of breath, and chest pain. We use imaging scans like CT scans or X-rays to diagnose pneumonitis and assess its severity. Treatment usually involves high-dose corticosteroids like methylprednisolone to quickly reduce inflammation. If that doesn't work, we might try other immunosuppressants like mycophenolate or even tocilizumab, a monoclonal antibody that blocks a specific inflammatory pathway. Then you have rheumatologic toxicities. So now we're moving on to that musculoskeletal system. Immune checkpoint inhibitors can cause joint pain, muscle pain, and even inflammatory arthritis. It's like having a flare-up of rheumatoid arthritis, but instead of being caused by the underlying disease, it's triggered by an immune checkpoint inhibitor. For mild cases, we can often manage the pain with simple analgesics like paracetamol or NSAIDs like ibuprofen. If the pain is more severe or if there's inflammation, we might step up to corticosteroids like prednisone. And in some cases, we might even need to use DMARDs like methotrexate or biologic therapies like anti-TNF agents. So they're the big guns. But now let's venture into some of the less common but still important immune-related adverse events. So you have neurologic toxicity. Immune checkpoint inhibitors can sometimes affect the nervous system, leading to conditions like encephalitis, which is inflammation of the brain, or peripheral neuropathy, damage to the nerves outside of the brain and the spinal cord. Encephalitis is like a storm brewing in the brain, causing confusion, seizures, or even coma. This requires immediate hospitalization and high-dose corticosteroids like methylprednisolone, sometimes even in combination with other immunosuppressants. Peripheral neuropathy, on the other hand, is like a frayed electrical wire, leading to numbness, tingling, or weakness in the hands and feet. This might be managed with pain medications like gabapentin or pregabalin. Then you have cardiovascular toxicity. One of the most concerning immune-related adverse events is myocarditis, which is inflammation of the heart muscle. This can lead to chest pain, shortness of breath, and even heart failure in severe cases. Early recognition and prompt treatment are absolutely crucial. We're taking high-dose corticosteroids for this, like methylprednisolone, right off the bat. And if that's not enough, we might need to consider other immunosuppressants or even heart assist devices in severe cases. Then you have renal toxicities. So these agents can also affect the kidneys, most commonly causing a condition called acute interstitial nephritis. This is like an allergic reaction in the kidneys, leading to inflammation and damage. Symptoms can include decreased urine input, swelling in the legs, and changes in blood electrolytes. Treatment usually involves stopping the immune checkpoint inhibitor and starting high-dose corticosteroids like methylprednisolone. If the kidneys are severely affected, we might need to consider dialysis temporarily. Then you have hematologic toxicities. While less common, ICIs can also cause problems with the blood, such as anemia or thrombocytopenia that we've spoken on previous episodes. These might require blood transfusions or medications to stimulate red blood cell production, or in the case of thrombocytopenia, it might require a platelet transfusion or medications to boost platelet production. And then you have ocular toxicity as well. Findings sometimes can cause inflammation in the eyes, known as uveitis or orbital inflammation. Like having a speck of dust in your eye, but instead of being a minor irritation, it causes pain, redness, blurred vision, and even vision loss if not treated properly. Treatment usually involves topical corticosteroids like prednisolone, sedative eye drops, while in severe cases might need to use systemic corticosteroids or other immunosuppressants. Remember, this is just a brief overview of some of the most common immune-related adverse events. Key takeaway is that early recognition and prompt management are crucial for minimizing the impact of these side effects and ensuring that our patients can continue to benefit from immune checkpoint inhibitors. It's a team effort, much like a well-coordinated sports team where everyone has a role to play. The oncologists, they're the team captains here. They're making the big picture decisions about the treatment. Pharmacists like ourselves, we're the kit men. We're ensuring that the right medications are available and used correctly for those patients. The nurses then, they're like the athletic trainers. They're providing hands-on care and monitoring that patient or that player's progress. And sometimes we need to call in other specialists like endocrinologists, gastroenterologists, or rheumatologists, who they're like the specialist coaches for specific parts of the body. One of the most important players, or the most important player on the team, is the patient themselves. We need to educate them about immune-related adverse events, empowering them to recognize the signs and symptoms and report any concerns to us promptly. Think of it like giving them a team strategy so that they know what to expect and what to do if they encounter any challenges. This early warning system is crucial for catching immune-related adverse events early and preventing them from escalating. Regular monitoring is another key aspect of managing immune-related adverse events. This involves regular blood tests to check the liver and the kidney function, thyroid, hormone levels, and other important markers. We may also need to do imaging scans like CTs or MRIs to check for inflammation in different organs. If we do see signs of immune-related adverse events, we may need to adjust the dose of the immune checkpoint inhibitor or even interrupt treatment for a while. Whilst the immune-related adverse event is under control, we can usually resume treatment, but we need to be cautious and monitor the patient closely. It's important to remember that some immune-related adverse events can have long-term consequences. For example, hypothyroidism caused by immune checkpoint inhibitors may require lifelong hormone replacement therapy. That's why ongoing monitoring is so important, even after a patient has finished treatment. In addition to the strategies we've discussed, there are a few other practical tips for managing immune-related adverse events. Firstly, it's important to have a low threshold for investigating any new or worsening symptoms. It's better to be safe than sorry. So if you're not sure what's causing a symptom, it's always best to err on the side of caution and investigate further. Secondly, it's important to be familiar with the latest guidelines and recommendations for managing immune-related adverse events. This field is constantly evolving, and new treatments and management strategies are emerging all the time. By staying up to date with the latest research and publications, we can ensure that our patients are receiving the best possible care. That's why this episode is more of a brief overview of the concepts rather than being strictly driven by guidelines and recommendations in the current iteration, because otherwise this podcast will go out of date very, very quickly. Finally, it's important to remember that every patient is different. What works for one patient may not work for another. That's why it's so important to take a personalized approach to managing immune-related adverse events, tailoring treatment plans to the individual needs of each patient. By working together as a team and following these practical tips, we can effectively manage immune-related adverse events. Now, I also want to talk about a particularly tricky situation, which is called overlapping syndromes. Sometimes our superhero immune checkpoint inhibitors can cause a bit of a domino effect, triggering a cascade of immune-related adverse events that affect multiple organs simultaneously. It's like that superhero accidentally setting off a chain reaction that causes damage in unexpected places. One example of this is myocarditis myositis overlap syndrome. This is where the immune system attacks both the heart muscles and the skeletal systems. So heart muscles, myocarditis, and the skeletal systems, myositis. Patients might experience chest pain, shortness of breath, muscle weakness, and elevated levels of certain enzymes in their blood, like creatine kinase. This is a serious condition that requires prompt recognition and aggressive treatment with high-dose corticosteroids and other immunosuppressants. It's like a double whammy. We need to act fast to protect both the heart and the muscles. Another example is myasthenia gravis, which is a neuromuscular disorder that can occur along myositis or myocarditis. Myasthenia gravis is like a communication breakdown between the nerves and the muscles, leading to muscle weakness and fatigue. Patients might experience drooping eyelids, double vision, difficulty swallowing, or weakness in their arms and legs. This requires a multidisciplinary approach involving neurologists, cardiologists, and other specialists to manage the complex interplay of symptoms and ensure the patient receives the best possible care. Recognizing and managing overlapping syndromes can be challenging, but it's crucial for ensuring the best possible outcomes for our patients. So, said all those things, let's shift our focus now to the long-term management and follow-up of patients who have experienced immune-related adverse events. Even after the initial immune-related adverse event has resolved, it's important to continue monitoring patients for potential late onset or recurrent immune-related adverse events. Some immune-related adverse events, like hypothyroidism, can have lasting effects and may require lifelong treatment, as I've said earlier on, and that'll need ongoing management. Other immune-related adverse events, like pneumonitis, can recur even after the immune checkpoint inhibitor has been stopped. It's like a dormant volcano that can erupt again unexpectedly. That's why regular follow-up appointments are so important. We need to keep a close eye on our patients, monitoring their symptoms, blood tests, and imaging scans. We also need to maintain open communication with our patients, continuously educating them about the potential for long-term effects, and encouraging them to report any new or worsening symptoms promptly. And as I said earlier on, that this podcast is giving kind of an oversight of the handling of immune-related adverse events in their current iteration, but not delving too deeply into it. And that's because the field of immuno-oncology is constantly evolving, and new treatments for immune-related adverse events are emerging all the time. One exciting area of research is the development of targeted therapies that block specific inflammatory pathways, infliximab and tocilizumab being the first recommended for steroid refractory treatment. These therapies are like precision-guided missiles that we've talked about in previous episodes that can hone in on specific molecules that are causing the immune-related adverse event, minimizing the impact on other parts of the immune system. Another promising area is personalized medicine, where treatment is tailored to the individual patient's genetic makeup and other characteristics, rather than a one-size-fits-all approach. While these emerging therapies are still in early stages of development, they hold great promise for improving the management of immune-related adverse events and minimizing the impact on patients' lives. It's an exciting time to be working in this field, and I'm optimistic about the future of immune checkpoint inhibitors and how they can be handled. So there you have it, a whirlwind tour of immune checkpoint inhibitor toxicities. These drugs are incredibly powerful tools in our fight against cancer, but they do come with some risks. By understanding these risks and knowing how to manage them, we can ensure that our patients get the best possible outcomes. This podcast episode today has been highly influenced by the ESMO clinical practice guidelines on immunotherapy-related adverse events and the management of such. So if you want to learn more, I encourage you to check out those ESMO clinical practice guidelines. They provide much more detailed information and recommendations for managing immune-related adverse events. And thank you all, as always, for listening to the Irish Hematology Oncology podcast. If you enjoyed this episode, please share it with your colleagues and subscribe to the podcast for future episodes. Leave us a review on Spotify and Apple Podcasts, as I think that helps us get seen by others. And if you have any questions or topics you'd like me to cover, please don't hesitate to get in touch through, I have an Instagram social media channel at Irish Heme Onc Pod, that flicks up a couple of social stories from this podcast. You can also email me on irishhemeoncpodcast@gmail.com or through the feedback form, which is always posted in the show notes below. And as always, I'll end on this important disclaimer. This podcast is for educational purposes only. Remember, the field of cancer is always advancing, and new research may lead to changes in treatment approaches and safety protocols. Always consult with your healthcare providers for personalized guidance and discuss any information from this podcast with them. Seek information from local and national resources for the most up-to-date recommendations. Thanks as always, guys. I'll catch you next week.